So again, we'll now have an outstanding speaker again for us. The next talk will be by Dr. Satya Karna, which will be on Watch Out, Common Pitfalls in Neuro-Ophthalmology. And Satya Karna, again, an outstanding neuro-ophthalmologist. He practices neuro-ophthalmology at JP Hospital, Noida, with a lot of experience and a huge, very loyal patient base and a lot of wonderful cases he keeps putting on our group. So it is always a pleasure to listen to Dr. Satya. Dr. Satya, your talk, please.
Thank you, Rohit. I hope I'm audible.
Yeah, you are. Go ahead.
Okay. So let's see some pitfalls in neuro-ophthalmology. What is a pitfall? A pitfall is basically a hidden or unsuspected danger or difficulty. So when you look at this MRI, do you see, is there a lesion? Do you see any lesion? This is a plain MRI. And when you do the contrast MRI, you see how the lesion enhances. So the first pitfall is order the right investigation. You have to order an MRI with contrast. Plain MRI, according to me, is outdated. Provided, of course, the patient does not have any kidney disorder and the urea creatinine are normal. So not ordering the right test is the first pitfall. Let's see another example. A 39-year-old female who had recurrent pain in the right eye for 1 year, and she was treated elsewhere for optic neuritis with IV methylprednisolone twice with temporary relief of pain. When she came to me, she had a RAPD in the right eye of 1+. The best corrected visual acuity was 6.6 N8 and the left eye had 6.6 N6. The color vision in the right eye was quite poor. Ocular movements were full. And when you look at the fundus, look at the red-free picture at the bottom that shows much better. There is a disc edema in the right eye. So in essence, this patient had a persistent disc edema. It wasn't a disc edema which had resolved and recovered. So you have to think of something else. When we did the visual fields, the left eye, of course, had a few false negatives, but the right eye showed a gross constriction of the visual fields. So we go ahead and we did an OCT, which just confirmed the disc edema in the right eye, did not give us any extra information beyond that. But when we looked at the MRI, which had already been done elsewhere. If you look carefully at this MRI, you will notice that the optic nerve here on the right side has some kind of a sheathing. I mean, it is the enhancement of the optic nerve sheath rather than the optic nerve itself in the right orbit. And it is quite a long lesion. So this made me think a persistent disc edema with a patient who has an enhancing right optic nerve sheath. Look at this sagittal image here, look at this part here. And so my suspicion went towards a tumor and I asked for a CT scan. Why? Because I was looking for calcification. So now you can see a few spots here. You can see this tram track calcification. You can see another spot here, which is also seen here. So there are these few calcific spots, which confirms the diagnosis of an optic nerve sheath meningioma, and she was referred to the radiation oncologist for stereotactic radiotherapy. 80% of such cases, the vision stabilizes or improves, though the size of the lesion remains the same on long-term follow-up with stereotactic radiotherapy. So how do you avoid this pitfall? My habit is to look at the films first, assess the findings, and then see the report, and never look at the report given by the radiologist, because they are not clinicians and they will not give you all the findings that you want. Then after looking at the image, and if you feel it is inappropriate, please order the next appropriate test. Now let's change tracks here. There is a well-known entity called the great mimic. So as you can see, this patient, he has a ptosis and he has a limitation of elevation, depression, and a bit of adduction, abduction in the left eye, but it doesn't seem to be fitting into a typical third nerve palsy. So if you remember the great mimic, it is myasthenia gravis. Another case to show you an example, myasthenia gravis, which in this patient, when he looks to the right, he has a limitation of adduction in the right eye, and he has full movement in the right eye and limitation in the left eye. And when he looks to the left, he has a limitation of adduction in the right eye and full movement in the left eye. So one would be thinking of a bilateral internuclear ophthalmoplegia, but when you do the hydrophonium test, look at his eyes. They are orthophoric, and look at the eye movements. It's fantastic. So this is a very quick test, provided you have hydrophonium, of course. And this confirms that this patient had myasthenia and not bilateral INO. Another clinical sign which sometimes most general ophthalmologists miss is this. Now, when you have a patient who has persistent redness and no other history, and he's been treated for conjunctivitis and then glaucoma, and then he is just not getting better and the picture just looks the same all the time, then you have to really think. You have to look at the vessels closely. These are dilated tortuous corkscrew vessels. And see what he has on a CT scan. Even a simple CT scan with contrast can pick up there's a grossly enlarged right cavernous sinus. So this patient and this another patient, which again shows very dilated tortuous corkscrew vessels and with a dilated superior ophthalmic vein on a CT scan. And when the DSA was done, the patient was found to have a huge keratico-cavernous fistula. So this is another pitfall. Don't miss this. Dilated tortuous corkscrew vessels with proptosis is even more suggestive of keratico-cavernous fistula, and with ecchymosis is 100% pathognomonic of CCF. Another case, a slowly progressive drooping of the lid following a persistent headache, and this patient had limitation of adduction, abduction was full, limitation of depression, elevation. But if you look at the pupils carefully, the right pupil is dilated. No drops have been put. So MRI brain with contrast had already been done elsewhere. Where is the lesion? What next? Should we just refer it? No, we don't give steroids. We have to do an MRA. And look at this. Look at the aneurysm. Though it's so tiny, it's caused such a huge pupil involving right third nerve palsy. Another close-up view of that aneurysm. She underwent coiling of the ICA PCOM aneurysm. And the important point here is when you have an isolated third nerve palsy, you look at the degree of completeness of the external ophthalmoplegia, that is the external dysfunction part, and you look at the presence or absence of pupillary involvement, which is the internal dysfunction part. So this is very important, and this is the pitfall you should not drop into or fall into. And so she, after coiling, you can see that the aneurysm has been obliterated and there is very good recovery of eye movements in the right eye. Patient was very happy. So important thing is pupils. I suggest to do pupillary
1 minute left.
In all patients in the clinic. You should teach your optometrists, your juniors and everybody to do pupillary evaluation in all patients. This is an example of a pupil sparing third nerve palsy. Now let's come to the fourth case, which is vanishing visual field defects. A patient who had undergone LASIK but was complaining all the time. And she said, my vision is not good, my sight vision is not good. And when you look at the fields, it seems as if there are constricted fields in both the eyes, but look at it carefully. It is not that. When you do and thanks to All India Institute, which has the only gold man around here, they did the visual fields and it came out fully normal. So look at this and this clover leaf pattern, never miss this pattern. You have to repeat the fields again. You have to do a gold man, but you have to get the patient out of this so that you get a fully normal field and you can prove that there is no field defect. The last case, unexplained bilateral visual loss, which is a real pitfall. A 56-year-old male businessman from Dubai who had a progressive diminution of vision in both the eyes for the last 2 years, had hypertension, was diagnosed as pituitary adenoma. The prolactin was highly elevated and the VEP showed delayed latency. So there was this field defect where you can see a temporal hemianopia in the lower one and you can see a constriction on the upper one. I'm sorry. The patient was treated as a large pituitary adenoma, which was splaying, just a few slides, splaying the chiasm upwards, as you can see in these two pictures. And the third picture. The treatment was done, but after 5 weeks of cabergoline, the prolactin had reduced, but the patient noticed a further drop in the sight vision. The vision was 6/6, but when you look at the discs, there was temporal pallor and there was complete bitemporal hemianopia, which means there was a progression instead. So the patient had undergone a pituitary adenoma resection, but there was still a visual field loss. And so what did we find? We actually found a pit, and the chiasm had actually dropped into the pit. Look at this carefully. You can see the chiasm, the blue arrow has gone down. This is the normal anatomy, and the chiasm is way higher than the pituitary. And you can see in a normal MRI how the chiasm and the pituitary are related. But in this patient, this is another example of an empty sella where the chiasm is inked and there is an empty sella below it. And in our patient, you can see between the two MRIs, the chiasm had actually sunk into this in 2011. So the treatment for this was transsphenoidal chiasmopexy with fat graft. He retained his vision and visual fields, but then he further had bilateral loss of vision, which you see is progressive on the left eye. And then he underwent transsphenoidal chiasmopexy with silastic implant and titanium plate, and the vision was maintained. Thank you. And you're all invited to the Global Neuro-Ophthalmology Case Festival on September 26th and 27th.
Thank you very much, Dr. Satyakarna. They were wonderful series of very informative examples. I'm sure the general ophthalmologist who's hearing also would have gained a lot. Dr. Rohit, questions? Dr. Durga?
Yeah, I have a question, sir. Satyakarna, sir. When do you consider neuroimaging in a pupil sparing third nerve? Or do you consider neuroimaging in pupil sparing third nerve?
Okay, so that's a very important question. Actually, even if you have a pupil sparing third nerve palsy, which is isolated and there is no other neurological sign, and the patient is significantly diabetic or has other vasculopathic factors, you consider it as vasculopathic, but you have to wait and watch, and you have to review the patient within 2 weeks. If there is a pupillary involvement, or if it is painful, if there is persistent pain, then the patient requires neuroimaging. Or if the palsy is incomplete and starts progressing, I think even that is an indication to get neuroimaging done.
Any role for CT angiography?
Yes. So it is, or it has been discussed on various fora earlier that even CT angiography is as good or even better than MR angiography. And therefore, I think centers which have good CT scans with angiography should go ahead and do that.
Dr. Satya, I have a question.
Yes.
So I saw a case today, patient today with pituitary macroadenoma, not quite touching the chiasm, but the imaging showed exactly the same sort of kinking like the one you showed.
Yes.
And the patient did have a early supratemporal defect in one eye. And this case did not have an empty cella. It was an evolving pituitary adenoma. And it was exactly the same kinking effect that occurred. So I just wanted to share that information. And is it quite possible that growing pituitary adenoma can indeed kink a chiasm? It was exactly today afternoon I saw that patient. Or any other panelists, or Dr. Satya has similar experience in any other?
Yes, I believe there are reports where there is this kind of association. It is rare, but it can occur. And I think other panelists who have seen more such cases may comment on it.
I think secondary, yep, please go on. Dr.
Yeah, I was just wondering, we get some Sachin's view on.
Yes, so it depends on the morphology of the pituitary adenoma, the use of cabergoline, surgical resection. So it basically is a mechanical effect where you can either have a superior kink or an inferior kink, and you will see progressive anterior visual pathway defects. So OCT can pick it up sooner. The earliest you'll pick it up is on your visual fields. And if you pick it up before there are OCT changes, it's reversible.